So we'll start with a quote from Michelle Obama: "The communities and countries and ultimately the world are only as strong as the health of their women." And I bet you guys know this better than anyone. We all know, in fact, I think we're just about all women, that women are pretty good at holding up the sky for our communities and our societies. And as I say, probably even more so in the group that you guys are seeing. So, you know, I want to acknowledge the work that you do, because I think I spend a lot of time with my patients seeing women who have a pedestal of privilege, and the women that you see probably don't have the same. And I think that that's got, and you know, it's true good work that you're doing, so I applaud you for it. I think it's got implications with topics like vulval health, just from the point of view that it's an emotive topic at the best of times for all of us, for patients, for health practitioners. But for you guys, I think it is much more likely to be an area that's going to lead you down a rabbit hole, you know, a rabbit hole that involves, you know, sexual trauma or female genital mutilation, whatever it happens to be. And so for that reason, as I say, I think it might be even harder for you than it is for people like me. And so when you are approaching these topics, I think, you know, you can't underestimate the importance of self-care from a health practitioner's point of view. So this is the Great Wall of Vagina, which is actually much bigger than that. It's one of the artworks at Mona, which is the gallery outside Hobart. I think the good thing about this is that it shows me that the message is kind of getting out there. Because in general, I think nobody talks about vulvas, which is a great pity. And so having stuff like this is obviously getting it out in the open. And right from the very start, we know that we're much more likely to give the genitals of a baby boy a name than we are to give the genitals of a baby girl a name. And that's very interesting just from the point of view of how we go forward and how we're able to be at peace with our body and empowered about our bodies. And in my work experience, you know, there are women of every age, not just adolescents, right up until old age, who have trouble actually even naming their body parts. You know, I think it doesn't matter whether you're 14 or 40, you can be embarrassed to name body parts, but I also think people don't actually even know what their body parts really are from a vulval perspective. People constantly apologise for any natural body hair that they've got, and often they'll come with a symptom that they've had for, you know, 10 years. It's really affecting their life and they haven't told anyone about it, which is a bit of a tragedy. And so I had a bit of a soul search about what I could actually give to you guys in your work, because I know that you probably don't directly, you know, look at a vulva or examine a vulva very often. But what I'm hoping is that I can give you a little bit of comfort and familiarity in the area, a bit of a structure to think through things and to talk through things with people, and just some relevant practical information and something that you might find interesting as well. For patients, this provides them with validation of symptoms that often are not validated, and it can, if we address these issues, it can really impact on their quality of life, which is a rewarding part of this work. And so it is a tricky topic. It's tricky for patients, it's tricky for health workers, and it always has a strong emotional overlay. We need to take, for patients, we need to take into account their context, and so there's always a big backstory behind vulval issues. They might have had past physical or psychological trauma. There are obviously sort of socio-cultural, religious things that come into play, and there's always gender and there's always power. Lots of vulval conditions that we see in practice are chronic conditions, and I think that makes it really, again, difficult and emotive for patients. It has they have significant effects on their lives, and so, you know, it might affect relationships, it might affect their sexual lives, it might affect their sleep, and it might stop them exercising. So it can be quite wide-ranging. Also, historically, I think vulval conditions have been kind of labelled, given this kind of label of psychosomatic problems, and I think women are aware of that, and we need to help them remove that label. from the point of view of the health worker, we're all human, and I do think that health professionals suffer from embarrassment and lack of comfort in this area as well. There's also, of all the areas of medicine, it's probably one of the areas where there's quite a large lack of evidence-based information for us to go on, which makes it tricky as well. It's also multidisciplinary, so when you think about the vulva and how it works, there's kind of dermatology, infectious disease, sexual health, gynae, psychology, physio, there's all sorts of areas that it crosses over into, and that makes it tricky for any one particular professional to be all over it. Okay, so this is vulval anatomy 101, and this is probably relatively simplistic for all you guys. But what I would say about vulvas and their anatomy is have a look. You're all women, have a look at your own and encourage your patients to have a look at theirs. Get them to use a mirror, and these days with iPhones you can flip it around into selfie mode and have a look, use that to look, and we use that in practice sometimes, although I always say to people maybe don't take a photo. I think it's good to conceptualise, when you're thinking about vulval health, to conceptualise the vulva as, the vulva is all the external female genitalia, so all of that stuff there that you can see is the vulva. But it's good to conceptualise it as part of the skin. And the reason for this is that the skin is obviously, so it's delicate skin, and it's skin that's prone to be irritated if it's exposed to various things. And vulvas are exposed to a lot of stuff, There's discharge, there's menstrual products, there are panty liners, all sorts of things that the vulva is exposed to that it has to deal with. But it's not in isolation, and the vagina is obviously, the vaginal opening is part of it, but it's better to conceptualise the vagina as part of the pelvis that has influence on the vulva. Likewise, the pelvic floor provides sort of myofascial support around it, and the nervous system is really important. And when you think about the vulva, concepts of chronic pain and referred pain are really important to understand. The only thing that I would point out there is the vestibule, just from the point of view that the vestibule, which is often that area around the vaginal opening and around the urethra, is often the area where women get pain. And so, that kind of pinpoint pain, so women will complain of painful sex, but that's often the spot that's really tender. And so, how do women present with vulval problems? Well, it's often quite difficult for them to articulate, and we seem to see this thing of, it's one extreme or the other. They might have been not validated in the past, so they might avoid it altogether and not talk about it, in which case it's really useful for you to have little tricks and ways of bringing it up. Or they might realise that you're a person that's going to listen, and they might pour out the whole thing, which is going to have a long history and it's going to be really complex, and it often feels really jumbled in one of those areas where you think, good Lord, where am I going to start with this? And so it's really useful to use structured questioning, so to kind of have a structure in your head, because that always just seems to make things far more clear and easy. And also the use of clear and comfortable language, and language that the patient is comfortable with, is really important. So often I think the well woman check is a really good conduit to this area. I'm not absolutely sure how far you guys go into a well woman check, but I just have a bunch of things that kind of run off. And I'll always start by asking about periods and bleeding, so cycle length, how heavily you bleed, how much pain there is, then about sexual partners and contraception, and then about the symptoms. So, I will specifically ask about vaginal discharge, itch and irritation, dyspareunia or sexual pain, and whether the nature of that, you have to go into that, whether they have pelvic pain at any time in their cycle, the urinary system, including incontinence. And so the ones that have got stars on them there are the things that people don't ask about. So, people will often avoid asking about sexual pain. They often don't talk about incontinence, either urinary or fecal incontinence, and sexual trauma, obviously, just because it's a tricky topic. And it's also important to know about, babies that they've had. It's good to try and figure out patients' assumptions and beliefs around this, because it can really help you to kind of move in the right direction. Things that I think are common misconception are that everything that's itchy or irritated is thrush. And we know that sort of for long-term vulval irritation, probably only about 20% of it is thrush. And so that's kind of an important thing to keep in your head, I think. They really worry that things are transmissible, and so we can often reassure them from that perspective, because often these things are actually dermatological issues. They worry about cancer. They worry about how we treat them, and in particular, you know, a lot of these, as I say, dermatological things require long-term steroid use, and so often you really have to reassure people about that because they've got lots of myths and misconceptions about using steroids. And they also often think that they can't be helped because they've tried and nobody's kind of gone there for them. So what should you ask? Well, I think the whole thing lends itself to a bit of systemic approach, and like I said before, you know, it's not just one discipline. So thinking about the skin as a system, the sexual and reproductive health, the urine, the bowels, and the musculoskeletal system. And I gave a whole line to psychosocial because I think that that's actually a really important part of the whole thing. You need to remember to ask them, excuse me, about any medications they're on, because we'll not uncommonly see a medication reaction in the skin in that area, just because it's quite sensitive skin, and any allergies they've got, obviously. And the allergic thing is good from the point of view that, you know, an atopic person, so a person who gets, you know, eczema, hay fever, has allergies to everything, is much more likely to have problems with skin in that area and in general. And I can't emphasise enough how important it is to talk to people about their skin care. So because this skin is easy to irritate, people will often inadvertently irritate it in the way that they take care of it. So, you know, overwashing, using too much soap, and we'll talk about this in more detail, but it's just ubiquitous, and I think it's really important to educate people about this kind of stuff. Okay, so what actually is normal? And that picture is from, I don't know if you guys are aware of the Labia Library. Can you have a show of hands who's seen the Labia Library? Yeah, so it was an initiative of Women's Health Victoria, and it's fantastic. It's kind of aimed, I guess, at younger women, but just to highlight the massive normal variation that there is. And they talk about stuff in there, particularly, again, like that young women want to know that, you know, labia minora, 50% of them are longer than labia majora, and that they're different colours and they're usually asymmetric, and hair can go onto your legs and onto your bottom, all that kind of stuff that people think about and worry about, but never really ask anyone. So, you know, I would commend that to having a look, and they're really good at doing different, you know, different skin colours and all that kind of stuff as well, which is great. We talked about having a look before. And from the point of view of differences, just bear in mind that there are absolutely normal differences through the age span. So vulvas look different, obviously, you know, from birth to grave, but in particular, childbirth can have a major effect on how your vulva looks. And for all women, I think it's got a profound effect on how they feel about themselves and how they see themselves as a sexual being particularly. Okay. And so this is just, I guess, to highlight the age thing. And so on the left-hand side there is a younger vulva, and the little pointer is actually showing you a little postcoital split, but that was just from another slide. And on the right you can see an older vulva, and so, you know, the changes that happen when oestrogen kind of moves out of the picture. So things just become a bit less elastic, a bit drier, and that can cause, you know, a whole lot of issues of its own. And the other thing we see in practice is a lot of women coming to you with stuff that's absolutely normal that they're really worried about. And so all the normal little structures of a vulva are things that particularly young women, probably older women too, but they don't talk about it as much, worry about. And so I've just put up a couple of normal slides to show you some normal appearances. So these are called Fordyce spots, and if you run your finger over them, they just kind of feel rough, but they talk about them having a cobblestone appearance, and that's one of the completely normal things you'll see. And, oh yeah, they're both. All right, and that one, the one on the left, you can see just around there, these are just sebaceous glands that produce oily kind of stuff, but again, women really worry about this. And I think this one is maybe the most important. So, you know, this is around the vaginal opening, and they're sort of the hymenal remnants. And again, I don't know how much people talk to you guys about this stuff, but there's a lot of kind of myth around hymens. I do lots and lots of 6-week baby checks, and they don't have hymens. The vagina is a hole from the start. So this is an embryological kind of thing. And so that kind of myth of it breaking with sex and stuff is definitely embedded, and most of the time not true. But people just worry about the kind of fleshiness of this area. And you can see here, that projects relatively well. This is called papillomatosis, but it's in no way pathological. That's completely normal. But a lot of women will come to you thinking that that's warts. And so it's important, and I guess this is one of the times where, you know, when you see a lot of vulvas, you kind of get to know what's normal, but warts look different than this, even in that spot. So it's good to be able to reassure people if you can. And so what about examining? And I know you guys don't examine directly, but it's good for you to know what happens to people when they have an examination. And so there's a couple of scenarios that we can examine in. One is in an opportunistic kind of, an opportunistic situation. And so when somebody's doing a CST, which I'm sure you all know now is the new pap smear, or when they have symptoms. And why would you do an examination? So you might just do it to reassure a woman that she's normal. To educate her about her anatomy and to empower her from that perspective. You might do it to diagnose abnormality, and you might do it to allay a particular fear. And how do we examine? I think this is probably the most important part of this. Obviously, we always need to do it with consent and respect. And I always talk to women about control and say, you're in control. If there's anything you don't like, just tell me and we'll stop, or we'll do it differently or whatever. And I think that can make a real difference. It's obviously a really vulnerable thing for somebody to do, to kind of lie on a couch and spread their legs and let a stranger examine their genitals. And so they need to feel safe. From a doctor's perspective, you really need good light. Like, you know, without good light, you can't really do a good examination. And obviously the sheet. I think the language you use is really important. And I make a point every time I look at somebody, so, you know, whether I'm doing a CST or whatever, to say, you look healthy and normal. And the vast majority of women will say, oh, good, that's fantastic. And even if I see their cervix, it's like, oh, your cervix looks healthy. And I think it makes them feel much better about things. And you often need to follow their cues. And just stop if you need to stop. It doesn't matter if you don't do it today, you can do it some other day. Okay. Now, I've put a bit in here about female genital mutilation, mainly because I know it's really probably pertinent for you guys, but also I'm really aware that, you know, it's not something that I do from, you know, that I see in my practice, and so you may well know much more about it than me. So, you know, I'm sorry if I'm repeating a lot of stuff that you already know. So FGM is the ritual surgical removal of part or all of the external female genitalia. And there's quite a confronting picture of some of the knives that are used to do it. It's contrary probably to relatively popular belief. It's not a religious Islamic practice, but I think often we will see it in Islamic women. In Australia, there are about 200,000 women and girls who are affected by it, so it's not a small number. And that 200,000 is people who have actually had a procedure done to them or who are at risk of having a procedure done. And obviously, as you probably know, that does occur. It does occur in Australia. The communities that we might most often see it in are sort of African communities, probably most of the time, but also parts of the Middle East and Asia. The World Health Organization classifies it into 4 types. Type 1 is the excision of the prepuce or the clitoral hood, plus or minus part of the clitoris. Type 2 is that including the labia minora. And type 3 is infibulation. I'll talk about that a little bit more on the next slide. And then the 4th type is just kind of puts everything else into a bit of a space that's unclassified. So it can be kind of any kind of pricking or scraping or piercing or cautery or all sorts of things that happen. The Royal College of General Practitioners has put out a fabulous document, which is actually called Female Genital Cosmetic Surgery, which doesn't sound like it kind of fits with this, but there's some really good stuff about this in there, if you're interested. And so this is the type 4. This is infibulation, and I think, you know, even that schematic kind of diagram is quite confronting. And it's one of these areas that I think that we really, if we come across this, particularly if we're surprised by it, we really need to try and manage our own feelings and take a patient-centred approach. This is illegal in Australia, and it's almost always got significant physical and psychological sequelae for a woman. And so, you know, physically she might have issues with menstruation, with periods, with passing urine, getting recurrent infections, and obviously pain and sexual problems. It's really important to ask, so because again, it's one of the things that people won't volunteer, and you need to be non-judgmental and use comfortable language. And so female cutting or female circumcision apparently is more comfortable for women when you're talking about it. And offer help, you know, even if you're not absolutely sure what you as an individual can do, other people are out there who can help, so offer that help on their behalf. And also consider these women's daughters, because, you know, even, as I said, even though we're living in Australia, these things can happen in the next generation. What we see practically from a medical perspective is that sometimes you can't do a speculum examination in these people, and often it all comes to bear around childbirth. And so people who've had an infibulation obviously need an anterior episiotomy when they're having a baby. The common practice here, and I think most of these women end up at the Royal Women's, is to, when you've done anterior episiotomy, just to control bleeding and to leave it as it is. But it's really important to have these discussions during the pregnancy with a woman because some people actually request for it to be all put back together, which of course causes some ethical issues. Okay, and so how do people present? Well, you know, like everything else, common things are common. And I'm going to go through just a bunch of cases for you, partly because it's just good fun to look at photos and it helps you to remember the conditions. But broadly, you know, you can divide them into things that itch and irritate, things that cause pain and soreness, which may or may not be related to sex. And then there's lumps, bumps and rashes. And obviously there's overlap of all these things. Okay. And I know this is not your particular area, but I'm going to try and get you to participate a bit in this if you can. And so the first person we're going to talk about is Anita, who's 28. She's got 3 months of vulval irritation, soreness and intermittent itch. Her skin burns when she wheezes, and she's concerned that she's got an increasing amount of creamy discharge. And now she's wearing a panty liner every day. She's got a relevant past history of childhood eczema, and she gets hay fever in spring. So I guess I'll throw it open. What's everyone thinking about Anita? Don't worry if you don't know, just have a crack. Yeah, terrific. Exactly. Okay, so that's what she looks like. And, well, that's what part of her looks like. And so this is, you can see this is like a local dermatitic reaction. And it's hard to know how it started, but the fact that she's wearing liners every day almost certainly means that that's contributing to it. So having something sort of artificial against her skin, probably something that's got perfumes added to it and chemicals is really relevant. You've got to try and stop people using everyday liners. And it's a self-fulfilling prophecy because the more irritation they get, the more discharge they get, and then the more they're going to wear the liner. So this is the most common cause of sort of ongoing vulval symptoms. So think of, skin stuff, dermatitis, eczema. We talked about the fact that all that itches is not thrush, and this is a case in point. And here she's probably got a component of her endogenous eczema, so that's probably part of it. Plus she's had some exogenous irritation as well. So, from the liners plus or minus other things. How would you manage this? Well, I think in all of these conditions, modifying the environment and thinking about skincare is absolutely the key. So, removing the allergen, in this case the liners, is really going to make a massive difference to how it turns out for her. As with all eczema or dermatitis, you want to treat the dryness, and that might mean removing particularly soaps and things like that she's using and replacing them either just with water or with non-soap alternatives, and getting some moisture back into the skin. And so for these women, I'll often say to them, if you're comfortable, just put a pump pack of Sorboline in the shower. It's cheap, there's a whole lot of it, and you can use it like a liquid cleanser. It's obviously not, it's a moisturiser, but you do come out cleansed and getting some moisture into the skin as well. And if you're going to put a moisturiser on afterwards, I always really highly recommend Dermese, because Dermese, again, it's it's a big tub, it's cheap, it's Vaseline-y, so it's quite oily, which some people don't like, but it's super at getting some moisture back into the skin. And then obviously in some people you need to go that step further and add in a topical steroid, and usually a low potent thing, just a Hydrocort or something, is totally fine for these conditions. Did you have a question?
So when you discharge, as with a red herring, is that related to the irritation?
So that's related to the irritation, probably the irritation associated with wearing liners. So liners will often cause a bit of a vaginitis, which causes increased activity of the glands and more discharge. Yeah. Okay, so the next one's Rachel. She's 38. This one's a bit trickier. She's got several years of intermittent, intense vulval itch, which wakes her up at night. And anything that wakes you up at night, you need to think hard about. It's a problem. She becomes red and excoriated because she scratches so much. She improves a bit if she puts some steroid cream on, but it seems to have a mind of its own. It just comes and goes when it wants to. She thinks perhaps it gets worse when she's stressed, which I think skin's a good barometer for that, isn't it? And maybe most pertinently, she's got a similar itchy patch on her elbow that comes up from time to time. And she's also got a family history of thyroid disease, so we're thinking kind of autoimmune. Anyone got any ideas? No? Who said that? What'd you say?
Psoriasis.
Awesome. Yeah, well done. Yeah, she's got psoriasis. She needs a clap. So there it is. So that's psoriasis on a vulva. This is, it's not as common as eczema dermatitis, but it still is relatively common, obviously, particularly in people who have psoriasis in other areas. So think of it. It looks a little bit different on vulvas. Generally, it's got less of that kind of scale and plaque, and psoriasis in other spots is usually really well demarcated. It has that geographical kind of edge, and it can look a bit different. You can kind of see that in that. There's sort of a few of those features, but they're not quite as clear as they are when they happen on knees or elbows. The treatment, again, is about good skincare. You can use a topical steroid, probably quite low potency again. And then there are all the psoriasis-specific preparations, tar-based things, etc. There's lots of them. Okay, so we're going to go on to Hannah, who's a bit younger. She's 18, and she's had 1 week of vulval itch, and she's scratching during her sleep as well. She also feels irritated on the outside, and she finds it's worse when she wears tight jeans or after she's had sex. She's also got an increased volume of white discharge, and she's had similar episodes in the past. They seem to come before her period starts and will improve when she starts to bleed. Any ideas?
Thrush, maybe?
Yeah, good job. Yeah, so this is your classic thrush. What's that?
I said that here with the tight clothes and the white discharge.
Yeah, that's right. Yeah. And they call it the white cottage cheese discharge, which is kind of gross. And so that's what it might look like. So, I guess things to say about acute thrush. Some women will come with it and some women just treat it out in the community. But 20% of people who get, well, in fact, 20% of women overall carry the Candida yeast as part of their normal flora. And it just needs optimum conditions to kind of take hold and produce an infection. So, it likes warm, it likes wet, it likes estrogen, and unfortunately it likes kind of alkaline conditions too, so it fits perfectly with semen because it's kind of warm and wet, it's alkaline, and so, that can be a precipitator for some women. To have thrush, this is another really good thing to remember, is that pretty much you need estrogen. So if you're prepubertal or postmenopausal, you really don't tend to see thrush. Young girls little ones will often get vulval irritation, but most of the time it's due to exogenous irritants. So bubble bath is the classic one. So yeah, mamas will often be putting Canestin on their little girls, but it's not thrush. And likewise, postmenopausally, unless you're having estrogen, so if you're taking hormone replacement therapy, or if you're using, vaginal estrogen, then that increases your risk of thrush. But otherwise, women postmenopause don't tend to get thrush. It's really quite rare but possible for acute thrush to infect partners. And male partners who have foreskins are a bit more susceptible, just from the point of view that under the foreskin is warm and wet. So, if you don't have foreskin, you're a bit more out there, and the thrush doesn't like it as much. And if men do get it, they get tiny little red dots on the head of the penis, and so they don't get discharge. So, if people are worried their partner has a discharge, it's not about thrush. From the point of view of treatment, you guys probably know all this. You can do the topical stuff, and it's really important if people are doing topical stuff to explain to them that they need to do the vulva and the vagina, because if you rub Canestin on the outside, it feels better, but the thrush infection is also high up in the vagina, so you need to get something up there, whether it's a pessary or a cream with an applicator. Or you can just use the systemic, diflucan, fluconazole kind of thing, which tends to work very well in acute conditions. Skincare, again, is important. And from the point of view of relieving itch, it can be crazy itchy. And so cold packs are good. And I'll often tell people to wet a face washer and put it in the fridge and then just, put it on, particularly if they're itching in bed at night. And also putting a barrier cream like the Dermies we were talking about, putting that in the fridge as well is good. Putting on something that's just kind of cold and creates a bit of soothing can really make a difference. And so I think probably, when you've got an infection like thrush, your normal flora is upset anyway. And so from the point of view of trying to get it back, our aim is to get rid of the thrush infection and then to let it recover. And probably, even though it's topical, you're probably going to change things regardless of whether you're taking something systemically or whether you're doing it topically. The time that there can be an issue with putting on topical things, and we might talk about this a bit later with a chronic irritation case, is that often if people put a lot of this stuff on, they start getting sensitive to the actual cream as well, and the cream will give them a sort of an irritant dermatitis. Okay, so the next one is a male. She's 26. She's had 7 months of vulvovaginal pain and an inability to have any sex sort of penile vaginal intercourse at all since she was married. She says that when he tries to put his penis in, it feels like a brick wall. And recently it's got to the point where she's unable to put in a tampon, and she's getting pain also when she rides her bike. When we question her about it particularly, she says that she has got a small amount of kind of a milky discharge, which is unusual for her. And she gets vulval swelling and burning after she tries to have sex. Any ideas?
Is there an allergy or something with the swelling and things?
There could be. That's a good thought. So it turns out that it's not, but that's a good thought. Swelling is actually a really important symptom from the point of view that not much else causes swelling except thrush. And so it's another one of those pointers that's kind of good to know. So this is a case, so RVVC is recurrent vulvovaginal candidiasis, so this is a recurrent thrush. And vulval clinics are full of these women who have had recurrent thrush that they can't get on top of, and then they develop this kind of pain syndrome. And so this, like I say, this is something that we see quite a lot of in people who have got chronic problems. And you can see here the chronic thrush vulva, this one, looks really quite different than the acute one from the point of view, and you don't get the classic symptoms. So you often don't get that cottage cheesy discharge and the itch. So often there'll be little or no itch. It'll be just this kind of more of a red raw, a little bit of milky discharge, and not much of the classic symptoms. And you can see the picture on the right there is after the candida has been effectively treated. So the difference in the sort of that inflammatory look is quite marked. In general, the way that we approach this kind of stuff when we see somebody, because her presentation is with sexual pain, and really it's almost impossible to assess the pain until you sort the skin out. So that's often a place that we start, is to think, okay, we need to sort the skin out, and then after that, then we'll have a look whether there's any pain left at all, and if there is, what we do about it. Just sort of flying a flag for vulval pain, it is super, super common. Women don't talk about it, but they say that up to 1 in 5 women has some sort of vulval or sexual pain. And so this is something that we really need to be thinking about when we're talking to our women. And just by the by, I don't know if any of you guys have listened to the ABC podcast, Ladies We Need to Talk. Yeah, and so not the current episode, but the one before is about vulval pain, and there's some really powerful accounts from women about what it's like to live with this kind of vulval pain. So I'd sort of commend that to you. That was terrific. Again, and probably more importantly than any of the others that we've seen, having good skincare here is essential. You've got to start with the building blocks and move on up. Treating chronic thrush, really the mainstay of treatment is to use fluconazole, which you might know as diflucan, and the big thing is to be not scared of it. I think, historically we used to say that it could cause liver problems, but really, it can, but it's super, super safe, although not in pregnancy, so you have to make sure people aren't pregnant. But really what we do is really hit it hard, and so we'll often give them the diflucan dose, the 150 milligrams, for 4 days in a row to try and knock it off. So normally the dose is just once. And then once the thrush is gone, then we'll give them a suppressive or a preventative treatment for, usually about 6 months. And so it'll be usually that, 1 tablet once a week for 6 months. But it varies between women, and we just kind of play with it until we get the right dose. But there's some evidence that if you suppress it for long enough, it's less likely to come back. And so we don't really get that, but it's the case. You sometimes have to consider a topical steroid in these women as well, because sometimes they've got a component of dermatitis. One of the important things, I think, is to tell them not to have any sex until this is sorted out, and that can be hard, but often having sort of increased pain stimulus just upsets the problem more and more. And so if you can kind of get them to stop, even if it's for a couple of weeks or a month until things are better, you can get ahead much better. They need really...
So what are the indicators for them that it's okay to start having sex? Or is the doctor going to say, it looks fine, go ahead?
Yes, and look, usually, in general, it's a massive relief if you say, don't have sex until this feels better, because, they've got all this pressure and this guilt. And so you can take it, you can do it yourself. The other people that are fabulous at doing this are the pelvic floor physios. And so one of the mainstay of treatment for these women is to have some pelvic floor physio. They often need something called down training. And so you guys would know, when you've got, when you're stressed, say, you often hold your neck and your shoulders, maybe your jaw tight, and you don't really even know. And it just becomes your resting state. And somebody kind of says to you, let all that go, and it just goes. So these women end up having a pelvis like that. So it's always on. And they've often got really good pelvic floor strength. but it's often a bit uncoordinated, and often they never let go. They're just on all the time. And so having a physio to help them understand how that works and to let it go can really make a huge difference to how they pan out. Sorry, what was the question? Did I answer it?
You did, but also...
oh yeah, when can they have sex?
Treatment can go for 6 months. So you're saying hit it hard and then...
Yeah, so look, generally it'll be when the acute inflammation dies down, which will be probably just after your initial treatment, when you're kind of looking like that, then you reassess, you look to see whether there's any sort of ongoing pain, which is separate from the skin infection, and then you can kind of assess the pain and treat that. Really, it's just when the pain is not too bad anymore. Yeah. And if you, pardon me, if you do review them and they have got ongoing pain, then it becomes really a multidisciplinary thing, and it depends how they look a bit on who you refer them to. But like I said, the pelvic floor physio, I think, is the person who can really make the most difference. And having like a little list of them who you know are great really makes a difference. They might need some sexual health counselling. They might need a gynaecologist. They might need a dermatologist. It just kind of depends on the picture. Okay, so the next one's Sarah. She's 48, she's a bit older. And she presents with, this one's a bit tricky too, so don't worry if you don't get this, with 5 to 6 years of mild vulval itch. So just kind of, some low-grade irritation. Having sex is uncomfortable, and she gets a bit of skin splitting as well when she has intercourse. She's tried over-the-counter antifungals and steroids, and they give her mild, short-lived improvement. Actually, I think I'm not even going to ask you this. I'm actually going to show you the picture first, because I think the picture is you need to see this one to have a crack at it. Okay, so that's what she looks like when you look at her. Has anyone got any ideas what that might be? Oh, it's up the top. Okay, so that's lichen sclerosus. That's hilarious. And so this is one of those things that is, overall uncommon, but in vulval practice, really, it's quite common. And once you've got an awareness of it, and particularly if you're doing lots of cervical screening, you'll pick them up. Like, I would pick up, I don't know, maybe 4 or 5 a year, something like that, just because you're kind of aware of what you're looking for. And it's that classical whitening of the skin. And so the whitening is generally sort of in the vulval area, but can extend down around the perianal region as well. So it's important to look down there. And LS can actually occur in the mouth as well. But if you see whiteness, that's what you need to think about. The other time that you think about it, so what this disease does over time is causes disruption to the architecture of the vulva, and everything kind of gets absorbed. And so and women will sometimes even actually say that. They'll say, my labia minora used to be this size and now they're almost non-existent, like they're really small. And so that's another time to prick up your ears. But if you leave active disease like this going, really everything can become quite stenosed. And so, you can have a vagina that's not, big enough for sex anymore, and everything can become really just quite tight and uncomfortable. There's also a link to squamous cell carcinoma of the vulva. And for that reason, and so someone with LS, their lifetime risk is about 5% of developing an SCC of their vulva. And so these women, it's vitally important that you pick them up and that they get ongoing surveillance. And so they need somebody to look at them and make sure that they haven't got active disease, that they're being treated well for the rest of their lives. Again, they need good skincare, and they need a high potency topical steroid. And when we diagnose it, we'll use something like diprazone, which is one of the really strong ones, twice a day for 10 weeks. And then, over time we'll gradually reduce that. And most women end up using a high potency steroid once or twice a week, always. And they need lots of reassurance that that's okay and that the pros outweigh the cons.
The pharmacists also need reassurance too, Felicity.
The pharmacists do need reassurance, yeah.
Often they'll say, you shouldn't be using this. I don't know what women say that.
Yeah.
And the dermatologist who works at Gene House says that too.
Yeah, that's true. I think everybody who buys steroids gets that message from the pharmacist. It doesn't matter whether it's hydrocort or, but obviously particularly the high potency things. It's true. They need lots of education, and there's not heaps of great patient stuff around this, but you know, websites like the Jean Hales website is quite good. The Melbourne Sexual Health website I think is particularly good for this, and they actually have a fact sheet to give to women to give to their doctors, which is really good because you know most people don't know a whole lot about this condition. And I guess the other thing to say is that with the frequent follow-up of these women, photography is really useful so you can see what's happening over time. And that's not possible, obviously, in all clinical scenarios because you need to have a proper system and ethics and all that kind of stuff. I will often get women to, each time we see one another, to take a picture with their phone, or I'll take the picture for them and to put it in a safe space so they can be the custodian of the photos, but you know, we can follow it over time. And sadly, this is what can happen if you don't treat it. So this here, you can see this is on sort of the posterior fourchette, or the posterior part of the vaginal opening. This is VIN, which is the equivalent of CIN, yeah? So vulval intraepithelial neoplasia, the precancerous part, and it often looks like this. So a kind of bit of thickened macerated skin that's a little bit grey, but it can look quite different. And if that's not picked up and not acted on, then obviously it can become something terrible, and that's a carcinoma. All right. So now we've got Ruth, who's 62. We're getting to the other end of the age spectrum. She's got 5 years of increasing discomfort with intercourse and what we call vulval awareness. So most of us, when we're healthy, just don't even notice that bit of our body's around, but she's aware of it all the time. She kind of got a sense that there's something happening down there. She's had 2 babies in the past. The first one was a big baby and needed a forceps delivery. And after she gave birth, she had a little bit of urinary incontinence when she sneezed and laughed. But recently she's losing, you know, larger amounts, and it's usually when her bladder is full rather than when she sneezes. Anyone got any ideas about her? Could be a prolapse, yeah. So I'm probably going to talk about something that's slightly even more common than a prolapse, but yeah, it could be a prolapse, and that might be a component of it. So really, what we're talking about here is what we call the genitourinary syndrome of menopause, you know, which which is, you know, it's caused by estrogen deficiency, basically, and you know, you might have heard of it as being the atrophic vulva or atrophic vulvovaginitis, but it's the syndrome that occurs around the time of menopause and really just has to do with the deficiency of estrogen, and this is the same one as before. And women will present complaining of dryness, of pain when they have sex, and just of that discomfort and awareness. Skincare can really make a difference with these people, and these are the ones who I tell to put sorbolene in the shower and then put something on afterwards as well. And the mainstay of treatment is really replacing the estrogen. So you can do that topically. So you can, you know, there's Vagifem or Ovestin, the estrogen that you can put inside the vagina, and that takes a little while to work. But once you've been using it for, you know, a month or so, it does a really good job. And occasionally we will give people systemic therapy too. So that's sort of, you know, hormone replacement therapy type dose systemically, and that works well. And again, can take some time to work. Again, you want to consider a steroid because often by the time they get to you, there's a component of a dermatitis as well. And from the point of view of incontinence, obviously we mentioned babies, and you know, probably she's had some pelvic floor damage when she's had her babies, but it's often when the estrogen kind of exits the scene that the incontinence symptoms really come into their own. So, you know, prolapses potentially get bigger, and just the fact that the tissue is less elastic can make a massive difference to continence. And so think about that. And giving them some estrogen and telling them to go to a pelvic physio can usually do everything that they need doing. You know, obviously sometimes there's surgery and all that kind of stuff, but that's the end of the line. And also, again, to wave a flag for faecal incontinence, don't forget to ask people because they won't volunteer if they're having problems with faecal incontinence. Okay, so now we've gone back to a youngie again. And we're going to move into the kind of more STI infectious disease space now when we're thinking about, or in fact, when we were talking about people before, this is going to be the lumps, bumps, rashes bit. So Molly's 20. She's had a couple of weeks where she's noticed lots of small lumps around her vulva and her inner thighs, and they seem to be increasing in number at quite a rapid rate. They're really pretty asymptomatic, but sometimes they're a little bit itchy or irritated. And she's noticed that her partner possibly has a couple of the same lesions. Anyone got any ideas what that could be?
Herpes?
Possibly. Yeah. Generally, herpes will present as more irritating and painful. That's possible, yeah. And common. Okay, so this is molluscum. And this is actually super common, particularly in young people. And you guys would probably be the most au fait with it on the torso of a 3-year-old. So kids get this a lot, and yeah, it's often on little people's chests, but it can be anywhere on their bodies. And it's spread by close contact and often through swimming pools. So we don't, I don't know if it's the water or the wet towels or whatever, but that kind of warm, moist environment can spread it. But it is also sexually transmitted, that kind of skin-to-skin contact. It's super common. And it's generally self-limiting, and so you can tell people that, but the self-limiting is tricky because, it can be 2 weeks or it can be 2 years, and the 2 years is often not so attractive. It's easy to do something about them, and so I get to the things, if you're actually looking at them, the things to look for, so you can see these little round patches, and when you look at them closely, they often have a little bit of a shiny appearance, and they've got a little, they call it an umbilication or a little dot in the middle, and they actually have a core. And if you squeeze them hard enough, the core pops out and they disappear. So people will sometimes do that. But, and that's actually a reasonable way to treat them if there's 2, but if there's, 50, then it's not a thing. So from the point of view of treatment, most of the time they're frozen off with liquid nitrogen. And they're really easy, you just give them a little squirt and within a couple of weeks usually they're gone. But you can, sometimes people will, scrape them off with a curette or squeeze them or whatever. But I think that the freezing with liquid nitrogen is probably the least traumatic. How are we going for time? Okay, we're going to go fast now. Okay, Claire, who's 25, has noticed lumps near her vagina when she's washing. They're generally asymptomatic, although they can be a bit irritated after she's had sex. And so pertinently, her parents declined the HPV vaccine at secondary school. Any ideas? What's that? Yeah, warts, exactly, warts. And so because of that vaccine, we're seeing less and less of this in practice, which is awesome to be able to see such a quick, response to a vaccine. But I imagine a lot of the people that you've seen won't have had the HPV vaccine. And so you can see just there, that's a wart. But genital warts can look vastly different depending on where they are. And so seeing one's not seeing them all. It is the most common STI still, but as I say, that will change with time. And it occurs in 1% to 2% of adults. It's spread by skin contact, and you can treat it in all sorts of ways with different wart paints and whatnot. But again, I think the cryotherapy, the freezing, most of the time is the thing that will work. Okay, so this is Supriya, she's 31. She has got 2 days of intense pain and burning on the right side of her vulva, which was initially a blister, but then it burst. She feels unwell, she's feverish, she feels fluey, and she's got a new partner of 3 months and he gets cold sores on his lips. What's it? Yeah, it's herpes. And so this is the acute herpes with I don't know if you can make that out there, but that's a whole bunch of little blisters, little coalescing blisters. And a couple of days later they'll break and they'll make a painful ulcer. The first ever infection is by far the worst. That's the one where you get big lymph nodes and you feel really crook and it's really painful. You can't wee because it's so sore. But generally after that, the symptoms, it's generally a bit better after that. But, again, the course varies enormously. You want to prevent infection in these people, so talk to them about good skincare and having a salt bath, maybe once a day when they've got, these lesions, just to prevent infection. You really need to manage their pain, so you can give them some topical xylocaine or, topical local anaesthetic. And if they're having trouble weeing, it's good to get them to wee in the bath. They need an antiviral, so, obviously you can use an antiviral acutely, and it'll usually be 5 days of treatment, which will shorten the duration and the severity of symptoms, and you want to get onto it quickly. And for people who are getting frequent attacks, then sometimes it's worth them being on an everyday dose to suppress. From the point of view of preventing spread, we know that taking a suppressive antiviral reduces spread by 50%, and condoms also reduce it by a further 50%. So condom use can be really tricky if you're with an ongoing partner to make that decision. But yeah, that's another whole story. Education and compassion here is key. People get really upset by having genital herpes. So this is Judy, and I think I kind of put her in because I saw a Judy the other day in my clinic at Jean Hales. She's got a couple of days of a left-sided vulval lump, which is increasing in size, and it is super, super tender. It's like a volcano. Any ideas? No. So it's called a Bartholin cyst. Yeah. So the Bartholin's gland opens sort of at the vaginal opening, and sometimes it can just get blocked in the natural course of things. And they look like this, and they really hurt. And the way to look after them is to, if you think that they're infected, to treat the infection, but pretty much they need surgical treatment, so they're off to the emergency department. And they do a thing called marsupialisation, where they actually kind of make a hole and suture it open, because otherwise they recur. Oh, okay. I think I've probably banged on enough about skincare, but I think that this is maybe your take-home point. This is the most important thing to think about. So avoiding irritants and things to think about: soaps, wipes, panty liners, perfumes, tea tree oil. People use a lot of tea tree oil and it's bad for vulvas, and even fabric softeners in your washing. You don't want to wash more than daily, and you want to be not using soap. You want to protect the skin and keep it dry, so cotton undies, barrier ointments if you need them, and regular moisturising. Minimise friction or rubbing. So women, particularly with the chronic conditions, will rub and itch a lot, and so even for things like wiping after the toilet, you have to say to them, just pat. Just, use a little bit and just pat, not for too long. And hair removal can be an issue, and so it's good to say to them, you know what, just take a break from that just for a while. Cool compresses we talked about, and some people will even need an antihistamine for irritation and itch. From the point of view of sex, water-based lube is the only lube that you can use with condoms, really, because oils can degrade condoms, but water-based lube, unfortunately, can irritate. So if people are in a situation where they need to use a water-based lube, get them to wash it off after they've had sex just with some water. But if you're not using condoms, oils are better, and probably olive oil, almond oil, veggie oil are the best ones to use. And from the point of view of first aid, if they're really angry, just so you can have a shallow bath of water with half a cup of salt, and that's really good. Or you can just use half a teaspoon in a litre and just do a bit of a soak, and that's quite soothing. Oh, and then I'm gonna. Have they got one of these, Louise? The vulva book? Yeah, so in your bag. So Jean Hales has got a vulva book, and that's got some good stuff about what to do with an irritated vulva. All right, so here's the take-home points. So lots of these conditions are chronic, they're often dermatological, and they require long-term management, and they are definitely not in people's heads. Assessment's everything, so you need to take a really good history and have a look. Regardless of the problem, modifying the environment, taking care of the skin is important. Take your time and share the load. So these are chronic conditions, they take a long time to get better, so you have to be patient. And you need more than just you. So, you know, here's your list of potential resources. I think it's really worth trying to dig out somebody who's a bit of a specialist in any of these fields. Unfortunately, even gynaes often have not been taught much about vulvas. And access is often an issue. So, you know, I think Jean Hales can be really good for this. That's a place where most people will be au fait with vulval conditions, and I think Family Planning Victoria as well. They're both good places to shoot people off to if they need help. Oh, and there's just some resources. So the Australian New Zealand Vulvovaginal Society is a great website, and that's got some really good stuff for patients, particularly about how to care for their skin. And I think Melbourne Sexual Health is great for that as well, as I said before. For the people who've got pain, the Pelvic Pain Society and this group called NOI are both fantastic. And if you guys are seeing people with pain in general, NOI, so that's the Neuro-Orthopedic Institute, they have got some amazing resources. They've got a book called Explain Pain that's really patient-friendly and fantastic for chronic pain type stuff. And then there's all that other stuff. The only thing I haven't put there that I would say is worth a look potentially, if you go to the Melbourne Sexual Health website, via that website you can look at what's called the STI Atlas. And so if there's anything weird and wonderful, there's hundreds of pictures there of all sorts of weird and wonderful things. And you guys might be seeing that. So you might be seeing the secondary syphilis or, you know, donovanosis or, you know, the weird and wonderful stuff that can happen with tropical disease. Thank you.